I went back and looked at the dates, and it reminded me that I was 5.5 months pregnant with my third child at the time. And I remember walking to the mother and feeling this child move inside of me. And when you have that maternal kick, you think to yourself, this is the worst thing that a mother could hear. And I remember sitting down with his parents and having to tell them that, in all honesty, that the Lord's in charge, but I really thought it was unlikely he was going to survive, and that they had to prepare themselves.
Dr. Duane was pretty good with telling us exactly what she had done and what they had found, and the issues with the lung and so forth. So, and he'd given us some warning that he wasn't going to look like himself. So, yeah, it was very dramatic when we first saw him.
That was just unreal. I couldn't believe it. And of course, we were both sitting there praying and hoping things would turn out for the best. But it was very emotional. We had other family members there with us, and it was just very difficult.
I mean, he was the sickest of the sick. Like I said, taking on all of our resources, I mean, really taxing them, using all of our critical care skills, technologies. And you know, when you see patients that sick, very few of them survive. He needed support for his cardiovascular system. That was not functioning on its own, so he needed help there. His lungs were in very bad shape, and it basically needed our most extreme type of ventilator. And again, it's not something we use a whole lot because patients usually aren't that sick, especially that quickly.
In a large trauma system like VCU, it's very important to work together as a team. With every service, communication is important to help make critical decisions towards the patient's care and triage the most important things to address first. And in Greg's case, definitive treatment of his orthopedic injury was delayed until he was stable enough to go to the operating room.
It was starting to look like he was actually paralyzed from the neck down. And so we got an MRI scan of the brain, and that showed that he actually had damage to his brain from lack of oxygen to the brain. He had been so sick that his nerves simply wouldn't work, and he was completely paralyzed for many days to weeks as a result of this, but gradually started to have some return of function.
Despite his slow neurologic improvement over the next few weeks, Greg is plagued with respiratory problems, unable to come off of the ventilator. His lung is not healing, and he requires a second chest surgery to remove an extensive infection. Each surgery weakens him, putting back his recovery by weeks. The tireless efforts of nurses Anthony Carandang, Kimberly Howard, and Kimberly Tate, along with trauma surgeon Michael Abatanas, bring him back each time. With this infection cleared, we are unable to get his lung to seal and remove his chest tubes. In order to avoid another major lung surgery in the midst of extensive scar, we call on our radiology colleague, Uma Prasad, to assist in his care.
He had chest x-ray which showed significant amount of air in his chest, for which they put a bigger chest tube. But down the line, we saw area of loculated collection which will not go away or will not decrease with the chest tube. So Dr. Duane came by and we reviewed his CT scan and the chest x-ray, and we decided that he needs a small catheter to be placed right at the area where there is an air collection.
There's a fatigue that the patient's feeling, that the family's feeling, that the health, that I'm feeling. Like, we've done all this work, I want him better. And, God humbles you, because he started having pain in the leg that had been repaired, appropriately repaired, but from the initial wound that he had with the crash, he developed a necrotizing infection in the leg. And when I saw it when he was on the ward and took him to the operating room and was in there and opened him up and saw how bad it was, that's when my heart sank, because this kid had fought and fought and fought, and I'm looking at this saying, I've got to take his leg off. And I called in Rao Ivachuri, my partner, give me your opinion. I called him Mark Willis from Orthopedics, give me your opinion. And then I took pictures, and I had to walk to that family. And I remember, because we all cried and said, I can't save his leg. It's gonna kill him if we don't take it.
I got involved with Greg's care when he continued to have pain where essentially where his leg used to be, when he had his leg amputated above the knee, and they were having a hard time getting control over it. He was doing better already, but there were still some adjustments that needed to be made to get him more comfortable. He had a patient-controlled analgesia machine, meaning a box with medication that he would get through his arm and his IV, and that he could press a button to get pain relief, and he was getting some continuously. But there are other medications that you can give in addition, what we call adjuvants, that also target neuropathic pain or nerve pain more specifically. And so in particular, I had to work with trying to adjust those medications to get him more comfortable.
Because of the dedication of our therapists, including occupational therapist Bridget Stockslater, he has regained some strength. Elizabeth Higgins has taught him how to swallow again and is an integral part of his brain rehabilitation assessment. He is now strong enough to tackle inpatient rehab, where he will be worked 3 hours a day by Dr. William McKinley along with LPN Evelyn Lindsay to get him ready to return to the life that was nearly destroyed one fateful April evening. After almost 3 full months in the hospital, Greg goes to the VCU Rehabilitation Service, who will take him to that next level.
Well, initially we were able to get him to start eating and drinking, and then we were looking at can he phonate with his trach, and we worked on that, and then we started saying, okay, let's see how your memory and your thinking's doing, because he came in on a Glasgow Coma scale of an 8, which means he really wasn't too with it. He wasn't alert, wasn't able to respond as we normally do. So speech pathology looks at cognition and communication. So in order to verbally communicate, you got to use your memory, you got to be able to put things together, you got to anticipate some things. So we're going to challenge him in memory kinds of tasks, in problem solving, in reasoning. So we started asking him questions and seeing how he could do. And he ended up doing very well.
Mentally, when you come into rehab being young, you have to look at what you have to endure, and you have to say, okay, I have to stay positive. So what I did was I would go in and we would talk, generally just talk, just let him be him. And so when he would, get up in the mornings, it was like a positive attitude. What are we going to work on today? He was into sports. He wanted to get back up on his feet so he could participate. He wanted to be normal.
He had enough underlying strength that you can work on resistive exercises to bring back strength. You can work on functional activities to bring back strength and then increase function. But then you also have to work on the issues of the medical management, manage the infection, manage the pain issues. And those were pretty significant issues when he first came to us, but luckily he made a lot of improvements.
It's nice to see someone that comes from a point where you don't think he's going to make it out and about in the community and doing normal stuff.
Every single one of them, they knew what they were doing, and they pulled him through. They pulled him through several times.
And it's because I was here, and my team was here, and my partners were here, and are always here, that a Greg Jones is a success story.
They're just very caring individuals. They see a lot of people come through day in and day out, and I know that they were following Greg very closely and really got to love him, I think. And he in turn loved them. It's just totally amazing what they did for him.